still trickling in, especially on this first day with registration and everything. So just a little bit of background. We'll start out the meetings with half-hour segments, 4 of them, called What's New in My Specialty. And this has for years been one of the most popular items of the conference. It used to be that these were longer talks, like an hour, and we decided to shorten them down to half-hour to get more speakers to talk about what's new in their specialty. So we'll have 4 this morning, half-hour each. Our first speaker is Dr. Megan Grunander, and she was raised in North Ogden, not far from here, attended Weber State, and then received a degree in zoology and chemistry. She obtained her medical degree at the University of Utah, and then completed a surgical internship at the University of California at San Francisco, and then a general surgery residency at Harbor UCLA Medical Center, and then a trauma surgical care fellowship at Cedars Sinai Medical Center. And she'll be speaking to us this morning on what's new in her specialty. And so let's welcome Dr. Grunander.
Good morning. It's truly an honor to be here. I feel really blessed to be able to come back to the community where I grew up and where I love so much. It's also an honor to hear from Dr. Milner, as she's done amazing things at Weber State, and as I'm an alumnus of there, I have strong ties to the Wildcats. After you see my talk in trauma, they'll probably never ask a trauma surgeon to start out speaking with breakfast, so I'll kind of apologize in advance. Before I get into the real thing you came to hear about today, I thought I would just start by letting you know a little bit about my training and where my love for trauma came. This is a picture of Moffitt Long Hospital, UCSF proper. It's a university setting, a tertiary hospital, and you see things there that you never see anywhere else. I was privileged to spend 6 months of my internship year here, countered with the other 6 months here at San Francisco General Hospital, which is in the Mission District of San Francisco. This was an eye-opening experience. As you know, there are no county facilities here in the state of Utah. My first day there was on trauma. I got 107 pages in a 24-hour period. I had about 70 trauma and acute care surgery patients under my care. And you learned very quickly you couldn't walk up the stairwell because the homeless people were there. So at one point during the year, they ended up actually blocking the stairwell off completely. And when you would walk through the trauma bay, you had to kind of weave through the drunk patients that were handcuffed to the gurneys. And some of them, despite having the spit mask on, continued to try to spit at you. So this was an eye-opening place. When my husband subsequently matched at USC the following year, I had the great privilege of transferring and completing the rest of my training here at Harbor UCLA Medical Center. This is also a county facility. Having never interviewed here and not knowing what this hospital was like, boy, was I in for a treat when I walked in the first day to take over the ICU. That was my first rotation. And in the summer, trauma with an encatchment area of Compton, Southgate, and Watts. You can only imagine what our summers were felt like. 7 deaths in the 2 first call days I had. A chief resident yelling at me over the phone how to put a chest tube in, having only seen one but never actually put one in myself, while he dealt with trauma down in the emergency room. It was a rare night that we didn't have a penetrating injury come through the ER when you were on trauma. I spent about 40 of my last 104 weeks as a resident as the trauma chief, and you really learn to manage your time well. It was not an uncommon thing to have a patient with abdominal viscera eviscerating out of their abdomen from a stab wound, as they were the more stable of the penetrating injuries that had come in at that night, and they would sit there with a moist towel over their open abdomen for sometimes several hours awaiting to be taken their turn to go to the operating room. The trauma bay was open. We would have one of my favorite memories is opposing gang members who had shot each other, fighting over which one of them I was going to take care of first and who they felt was more critically injured. Pulling a patient out of a burning room who had set himself on fire while smoking with his oxygen on while in an isolation room. It was truly a place that you could not wait to leave when you would be done with your shift, and now that I'm gone from it, I truly miss a lot, and I really am grateful for the training that I was able to receive here at Harbor. This is in stark contrast to where I did my fellowship. This is Cedars-Sinai Hospital. This white building here is the Saberstein Critical Care Tower. This building opened a year before I started my fellowship. It's a $125 million building. This only houses ICUs. You can see the glass bridge that hooks over to what is called the Max Factor Tower, which is the main portion of the hospital. Just outside of the picture is the Steven Spielberg Radiology Building, and this is all on George Burns Drive. So just quite the contrast from my other training. Our ICU was the 8th floor, the top floor, and it was a 24-bed unit for trauma, surgical patients, and neurosurgical patients. Everybody always wants to know, did I see celebrities? I saw a fair amount. We took care of some, took care of family members of others, would see some wandering through the hospital. And I feel really also honored to have been able to spend a year here learning and mastering trauma and surgery. It was at Harbor where my love for trauma grew. When I went into general surgery, I really thought I would be a plastic surgeon. And then after my first year at Harbor and in the ICU and trauma, my love for trauma grew, and I knew there was no way I could do anything but trauma. Here come the pictures. I apologize in advance. This is how I spent my last 6 years. There was a processing plant near Harbor's hospital, so a mangled extremity was not uncommon. Also, if any of you have ever driven on the 405 and you've watched the motorcyclists weave in and out, traumatic amputations, a common occurrence. During my year at Cedars-Sinai as a fellow, I actually had the rare opportunity to participate in the care of a mass casualty. This picture is the Chatsworth commuter train accident. I don't know if any of you heard about this. Happened in 2008. This is when a Metrolink commuter train, their driver was texting and failed to stop at a red light, and they collided head-on with a freight train. There were 24 casualties on scene. 1 patient subsequently died in a nearby hospital. 46 patients who were critically injured, 40 of whom required life flight transport to 12 surrounding trauma centers, and then another 100 and something patients who were transported by ambulance to the nearby trauma centers. While at Cedars, we accepted 10 of these critically injured patients, and it's amazing how when you have patients waiting in the recovery room and who often would stay there overnight because of a lack of ICU beds, how 10 ICU beds can miraculously become available in a matter of 30 minutes. It was a true experience to be a part of taking care of these patients. 6 of the patients we received ended up requiring intensive care unit level of care. And 4 were able to go to the floor. About 4 of them required emergency surgery. And I'm happy to say none of them passed away in our care. This is where my true love of trauma comes from. This is how most of our nights were spent, with penetrating injury. This is an example of a chest tube and an open wound from someone who's had a gunshot wound to the chest. This is what we call a clamshell thoracotomy. Here in Utah, these are pretty rare, as penetrating injuries are rare. I still hold the record at Harbor for having 3 in one night and 2 the following night. This is when patients come in with a penetrating injury to the chest, and they lose their vitals either en route or in the emergency department. If the patient's lucky enough to be able to make it from the emergency room to the operating room, this is kind of the carnage that we would leave in our trail. It only took putting 1 chest tube into a penetrating chest injury to learn to jump or wear shoe booties, because this truly is what you would then wear the rest of the evening. If the patients were able to make it from the operating room then to the ICU, the majority of them would end up with an open abdomen, which is what this is a picture of. The intestines swell secondary to the significant amount of fluid resuscitation that is required. And so you can't close the abdomen because it causes compartment syndrome. And oftentimes we would have to do what was damage control. So pack everything off, try to control the bleeding as best we could, hope to live another few hours, and then go back to fight another day. This is, again, another picture of a patient in the ICU. Everything swells, open abdomen, very difficult to care for, but very happy to say that by far and away the majority of the patients, when they got to this point, would walk out of the hospital alive. They'd have a large hernia from their open abdomen, and we would fix that later on. but many of them did live through this. So as I was trying to decide what to talk about today, I went back through the Journal of Trauma for about the last year and a half. And every month, without fail, there was an article about bleeding or hemorrhage or blood control. And so I felt like that was probably warranted a few minutes of my time. As I learned as an intern and was told very early on, all bleeding stops. You may not like how it stops, but all bleeding does eventually stop. So, why do we care about bleeding and trauma? Well, hemorrhage and bleeding is the leading cause of preventable death in a trauma patient. Of all trauma patients, 3% of them will require massive transfusion, and we'll get into more depth about what a massive transfusion is. One way that you can decide how severely injured your patient is this thing that we call the ABC score, the assessment of blood consumption. There's 4 components to this. Does the patient have a penetrating mechanism? Is their emergency room systolic blood pressure less than 90? Is their emergency room heart rate greater than 120? And do they have a positive FAST scan? For those of you that aren't familiar with FAST, this stands for Focused Assessment with Sonography and Trauma. This looks at 4 areas. You get a pericardial view, a perisplenic, perihepatic, and pelvic view. If there's free fluid in any of these places, then that's considered positive for a significant injury. If your score is less than 2, then you are less likely to require a massive transfusion or greater than 10 units of blood product. And this was shown to correctly identify 89% of patients who would require a massive transfusion. Just a little reminder about the classes of hemorrhagic shock. There are 4 classes of hemorrhagic shock. Class 1, you can lose up to 750 cc's of fluid and still be okay. You can see your heart rate remains normal, your blood pressure remains normal. You might become a little anxious, but otherwise, you stay hemodynamically stable. Class 2, up to 1.5 liters of blood loss and still be pretty stable. Your heart rate increases some, but your blood pressure overall stays pretty normal. Not until you get into class 3 and class 4 shock, where you're losing 2 liters or more of blood, do you start to become more hemodynamically unstable with elevated heart rate, diminished blood pressure, diminished urine output. This may be hard to see, and the letters are small. I'm sorry, we won't spend much time on this. This just kind of goes through the algorithm that as soon as a patient hits the emergency department as a trauma, we kind of very quickly, within the first 30 seconds, really begin to determine, are they hemodynamically stable or are they unstable? And then of those that are unstable, they very quickly fall into they either respond to fluid, they may transiently respond, or they don't respond. And that kind of also helps to classify them out as to the urgency and potentially the severity of their underlying injuries. So what are our resuscitation goals when these patients come in and hemorrhaging? Obviously, our goal is, number 1, to stop the bleeding. But then 2, once we've stopped and gotten control, how do we know when we've appropriately resuscitated the patient? So the goal of any resuscitation is to restore tissue perfusion, reestablish normal cellular metabolism, and prevent damage to end organs. So how do we know that we've done this? The patient will become hemodynamically stable. Their blood pressure will stabilize, their heart rate will stabilize. Their heart rate may remain elevated as they are having a catecholamine response in reaction to the trauma, but they do stabilize out. There will be a correction of the cellular oxygen debt, and this will be measured as either a mixed venous saturation if you have a Swan-Ganz catheter in, or a central venous saturation if you have just merely a central line. Most importantly is the correction of the lactate and the base deficit. As the overnight resident, when you were in the surgical ICU and a trauma would come in that day before overnight, the one thing, your sole job, besides keeping that patient alive, was to prove that their lactate and base deficit were correcting by morning. Because man, if they weren't, you heard about it. It meant that you didn't stand at that bedside long enough. So let's talk a little bit about pre-hospital resuscitation. This is something that's gained a lot of attention in the last few years about how the EMTs and paramedics should treat the patients in transport and in the field. It used to be 2 large bore IVs were placed and you hung 1 liter to each and you ran them wide open. That is no longer the teaching. They still should place 2 large bore IVs, but the fluid is now what has changed. The teaching now is if you have a systolic blood pressure of 90 or greater and you are mentating, no IV fluid is started in the field or en route. If fluid is given in transport, then it should not be greater than 2 liters of crystalloid. And there are a large amount of studies to show that large amounts of IV fluid replacement is related to early traumatic coagulopathy, organ failure, and sepsis. So what are our transfusion guidelines? Obviously, a patient that is bleeding, they need blood. But our transfusion triggers are probably a little lower than some of you may expect. A hemoglobin of 6 in a well-compensated patient without heart disease is very well tolerated. We would take turns during my ICU year rotating down through the medical ICU, and they as well would rotate through with us, and they would be flabbergasted as they would rotate with us, and we would have a hemoglobin of 6 or 7 in one of our post-trauma patients who was no longer bleeding, and were shocked that we wouldn't transfuse the patient. A hemoglobin of 8 in patients with stable cardiac disease and less than a half a liter of blood loss. And then the hemoglobin of 10 still holds true for older patients who cannot increase their cardiac output on their own and who are more likely to have more active cardiac disease. Just a quick reminder about blood products. When we do transfuse patients, what are they getting and how much? So 1 unit of blood is approximately 350 cc's of fluid. It has a hematocrit of 65 to 80 in just that 1 unit of blood, and you should expect to raise the hemoglobin 1 point for every 1 unit of blood given. FFP, it's 250 cc's of fluid, and this contains all of the coagulation factors except factor 5 and factor 8. Cryoprecipitate contains factor 8, fibrinogen, von Willebrand factor, and factor 13. And then platelets contain all of our clotting factors. So massive transfusion, I told you we'd come back to this. So massive transfusion is when a patient requires the entire replacement of their blood volume, which is approximately 10 units of packed red blood cells in an adult in 24 hours. I can tell you the most I've ever given a trauma patient in a lot less than 24 hours is 87 units of blood product. That patient did walk out of the hospital. With massive transfusion like that, you can imagine the things that come with it. Coagulopathy, part from dilutional, part also from the patient becoming hypothermic because the blood products are stored cold. You've all heard of that kind of fatal triad in trauma. Part of it is coagulopathy. Hyperkalemia and hypocalcemia can result as the degradation of the red cells begin during their storage process. So ratios. This is something that truly has been hit on in the last several years. A lot of this has come from the military. With an active war, a lot of studies come from the military. This is something that we have unfortunately benefited from the military experience currently. So this is the most current teaching. An FFP to packed red blood cell ratio of 1 to 1.5 is associated with improvement in survival not only at 12 hours, but also at 24 hours after admission. And in a separate study, FFP to a packed red blood cell ratio of 1 to 2, these patients were shown to receive a significantly fewer amount of blood component and did not require factor 7 as often. We'll go on to talk about factor 7. In patients, this is continuing on, in patients requiring massive transfusion, crystalloid resuscitation in a ratio greater than 1.5 liters of IV fluid to 1 unit of packed red blood cell was independently associated with a higher risk of multi-organ failure, acute respiratory distress syndrome, and acute coronary syndrome. So you can see this is again coming into also where that pre-hospital fluid resuscitation is so important. For platelets, they have not been able to find that kind of magic number that gives you a statistically significant survival benefit. However, I can tell you, at a level 1 trauma center with a massive transfusion packet, when you call for a massive transfusion box, it will hold 6 units of packed red blood cells, 2 to 4 units of FFP, and 1 unit of platelets. So for every 4 to 6 units of blood that you're giving, you should be giving a unit of platelets. This is an example of the massive transfusion protocol that we have in one of our Trauma 2 facilities here. We won't go into depth about it, but you can see it's a very close coordination with the blood bank, with lab, and everyone working together. Once the blood bank's notified that one massive transfusion box is needed, they really step up their game, and they have blood ready for us as we call for it. Autotransfusion. This is really important, particularly in patients with penetrating chest injuries. Autotransfusion is the salvage and reinfusion of shed blood from the hemorrhaging patient. What we do is with a pleurovac, which is what a chest tube is hooked up to, you place heparin or citrate within the pleurovac. And then once you put a chest tube in, or if you're doing a thoracotomy and you open the chest, you suction that blood out. It's heparinized, it passes through a filter, and you can turn around and then reinfuse this into the patient. We also do use this occasionally in the operating room. However, it's significantly limited in that if you have gastric, bile, stool contamination, that blood is unable to be autotransfused. Abdominal autotransfusion comes more into play with ruptured abdominal aortic aneurysms. In the LA area, there were a fair amount of Jehovah's Witness patients, and they obviously did not want blood transfusions. They would ask, what can I have instead of blood? Recombinant erythropoietin is something that they knew a lot about and they would always ask for. This is something that helps to stimulate your own body to kind of kick into overdrive when you've had an acute blood loss. However, there's a significant lag between administration and onset of the drug. So it is not appropriate in the acute setting. However, for trauma or surgical patients with sepsis who would then ensue a long ICU and hospital course, almost all of them would develop some sort of acute or acute on chronic kidney failure. And so erythropoietin was used quite frequently to help these sets of patients. Again, not helpful in the acute bleeding setting. Patients would also ask, well, is there some sort of artificial blood substitute? There are some. They are in clinical trials. There's one that's approved for use in Russia. There's one that's approved in some of the other Eastern European countries, but there are two that I know off the top of my head that are in clinical trials here in the US now, but none that are approved for use. Something to keep in mind, as these patients require all of this blood resuscitation, hemodilution can come into play, particularly if we fall out of our ratio and fall behind in giving our FFP and platelets. There's a strong correlation between the dilution of the hemoglobin, platelets, or fibrinogen, and then the coagulation parameters becoming out of whack and our patient continuing to bleed. These changes are most pronounced when the hemoglobin is less than 6, the platelets are less than 100,000, and the fibrinogen is less than 200. Something that the anesthesiologists use a lot, particularly in surgical patients, is called Hexstan or Hexspan. This is a starch-based plasma volume expander. It's great in the standard surgical patient. This is not good in trauma patients, as it was found in numerous studies to decrease their clotting ability more than 5% over that of albumin or crystalloid. And you will see at any major trauma center posted on the wall next to the anesthesiologist's head, no Hexstan or Hexspan in the trauma patient. This is just a quick reminder. Most of you probably haven't looked at this since the day before you took step 1, because that's when I looked at it and have promptly forgotten it ever since then. But this is we talk about how we overcome some of this coagulopathy of trauma. Just to show you here, you can see here trauma coming in, factor 7, which we're going to start to talk about, antithrombin here. This is all the extrinsic pathway, and then the intrinsic pathway and factor 9 over here. We're going to talk about both of these because they're used frequently in trauma resuscitation. So factor 7, some of you may have heard of it, some of you may not have. This appears to act at the site of injury in the presence of activated platelets, and it promotes a burst of thrombin formation that will help promote a coagulation plug. It's very rapid onset and a short half-life. I can tell you, I have used this numerous times in trauma patients when the major arterial bleeding you have under control, and there's just this persistent venous bleeding that you just can't sometimes get control of. Factor 7 is amazing. It's shown to improve 24-hour mortality, but not 30-day mortality. And this isn't that surprising, and that the patients that you're giving factor 7 to, you've kind of reached a desperation level of you just can't get the bleeding to stop. These are the patients you're packing off, their abdomens are open, and they've reached that fatal triad, and you're hoping to just get them through. But I have had a fair amount that have lived after receiving factor 7. The dose, it's easy to remember, 7 milligrams. Oh, 5 minutes. Okay, sorry. It is costly, however, $6,000 to $10,000 a dose, and there is significant concern in numerous studies they've shown to have thromboembolic events, CVAs, MIs, DVTs, and PEs. I've used it a number of times and never had any of this. Factor 9, prothrombin complex concentrate. It's rapid, it's effective, and it treats coagulopathy in patients on Coumadin, but also in patients in their response to trauma, for whatever reason, patients become coagulopathic. You will have a traumatic head injured patient that when they hit the ER, their INR is 1.6, and they are not on anticoagulants. Factor 9 is great for this, and this is first line for any of these patients. It's also relatively low in cost. Tranexamic acid, something that orthopedic surgeons have used for a fair amount of time and now making its way into trauma use. It's a derivative of lysine, and it works like Amicar. It's an antifibrinolytic. Sorry, we're running out of time, so I'll just skip through. This is a study that the military performed that showed that it improved coagulopathy and survival, most prominent in patients requiring massive transfusion, and without the thromboembolic events associated with factor 7. Quick clot, everyone asks about this. This is used in military. This is carried in all of the medics' packs. There's the Celox, which is a hemostatic gauze, and Quick clot, which is a powder. You can put it mainly into extremity wounds. It has an exothermic reaction. You're not to use it into the abdomen. We kept this on the shelf at Harbor where I trained, and I had sadly to admit, my goal was to use this before I left residency. I never got to. But up the road at LA County USC, the trauma surgeon did use it there in a 17-year-old girl with a retrohepatic IBC injury, and she was alive a year and a half later. So when your other alternative is death, the exothermic reaction is probably not so bad. Procoagulants, something to keep in mind, particularly in patients with chronic renal failure, they all have platelet dysfunction. DDAVP is something that has to be thought of and given. Protamine used more in cardiac patients who have been on heparin. It binds heparin and helps to neutralize that coagulant effect. Just finishing up here, lots of patients are on hemoactive drugs these days. Plavix, Pradaxa, Brilinta, Coumadin. Peripheral arterial disease and coronary artery disease are rampant, and all of these patients are on these drugs. Just some tips on how you can overcome some of these when they present to your emergency room bleeding. Plavix, aspirin, and NSAIDs, you administer platelets. Pradaxa, FFP, and factor 9. Hemodialysis will also eliminate 60% of the circulating drug when it's Pradaxa. Coumadin and low molecular weight heparin, FFP, vitamin K. Don't forget the vitamin K, give it IV. You can give it for 3 days. It significantly helps overcome the long-term effects of the Coumadin. Brilinta, one of the newer drugs, this is overcome with antifibrinolytic therapy such as Amicar or tranexamic acid. Important to remember, if you transfuse patients' platelets who are on Brilinta, it may actually inhibit it will inhibit the transfused platelets and make them non-functional as well. So in summary, hopefully you've been able to take away a little bit about the transfusion ratios, if nothing else. 2 units of blood, 1 unit of FFP. Once you start transfusing 4 to 6 units of blood, they need platelets. Their fibrinogen needs to be checked, and if it's less than 200, they need a pack of cryo. Our goals of resuscitation. The main key, correction of that lactate and that base deficit. That's when you know you're truly on the right track. And the treatment of coagulopathy, factor 7, factor 9, and trying to overcome some of these hemoactive drugs. This is my new baby girl. I had to show a picture of her. This is my 4-month-old Gracie. But any questions? All right. Well, thank you. It's been an honor to speak with you this morning.
If you want to do questions.
Oh, sure.
We have 2 mics set up. There's one over there.
Okay.
And then one right here, if you can see me. And then Teresa's going to be over there. So if anybody wants to have any questions.